Welcome to the deep dive. Today we're tackling something nearly everyone deals with at some point, back pain. You know, that ache, maybe a sharp twinge, especially in the lower back.
Absolutely. It's incredibly common. We're talking, what, 70, maybe 80% of people having a significant episode sometime in their life?
Huge numbers. And usually it's just
Well, yeah,
mechanical, right? A muscle strain, maybe a disc issue.
exactly. Most of the time, it's benign, nothing too serious going on. Usually resolves on its own or with simple treatment.
But here's the twist and why we're diving deep today. A very, very small percentage, like less than 1%, around 0.7% actually, of back pain cases aren't mechanical. They're caused by something like a spinal cord tumor.
It's rare, definitely. But recognizing those instances is absolutely critical. We talk about red flags or alert clinical signs.
Okay, what kind of red flags are we looking for?
Well, things like persistent radicular pain. That's that sharp shooting pain that follows a nerve path, often down a leg. Or maybe signs of an infection, fever, chills alongside the back pain.
Or a history of cancer.
Yes, that's a big one. If someone has a known history of cancer, new back pain could potentially signal metastasis, the cancer spreading to the spine.
So the goal here isn't to make everyone panic about their backache.
Not at all.
It's about being informed, giving you the insights you need to understand this complex topic, where these tumors live, what they are, how doctors find them, and what the treatment looks like.
Think of it as a shortcut to understanding a niche but important area. So where do we start? Maybe with the anatomy.
Good idea, because the location seems key. You mentioned these tumors can cause neurological problems.
Yes, that's the major concern. Regardless of the specific tumor type, they can compress or invade the spinal cord or nerves, leading to neurological compromise. This means issues with motor function weakness, difficulty walking, sensory changes like numbness or tingling, and potentially even problems with bladder or bowel control, sphincter dysfunction.
Wow. And you can actually pick up signs during a physical exam?
Often, yes. It's surprising, but positive findings on a neurological exam are present in up to maybe 55% of cases. Reflex changes, weakness, sensory loss. The clues can be there.
So let's talk location. How are these tumors classified based on where they sit in the spine?
Right. This is fundamental. We divide them into three main groups based on their relationship to the dura mater, that tough outer membrane covering the spinal cord, and the cord itself.
Okay, group one.
First, extradural tumors. These are outside the dura mater. They often involve the vertebrae, the bones of the spine, or the epidural space just outside the dura.
So on the bony side, mostly.
Yeah, finally, yes. Then, moving inwards, you have intradural extramedullary tumors. These are inside the dura, so within that protective sac, but outside the actual spinal cord tissue.
So in the fluid-filled space around the cord.
Exactly. They grow in the subarachnoid space, often arising from the nerve roots or the meninges, the layers covering the cord. They push the cord from the outside.
And the third type?
That's intramedullary tumors. These are within the substance of the spinal cord itself, growing right inside it.
And this classification, extradural, intradural, extramedullary, intramedullary, it really matters, doesn't it?
Hugely. It influences the symptoms, the types of tumors we expect to find, the prognosis, and definitely the surgical approach. It's the first big sorting step.
Okay, let's tackle them one by one, starting with the outermost, extradural tumors. What do these typically involve?
Extradural tumors are the most common location, actually. They can be either primary, meaning they start in the spine's structures.
Get the bone itself?
Right, originating in the bone or cartilage. Or they can be secondary, which means they are metastases cancer that has spread from somewhere else in the body.
Which is more common, primary or secondary?
Secondary, the metastases are much more common in adults for extradural tumors. But let's touch on the primary ones first. They can be benign or malignant.
Benign examples.
Common benign primary ones include things like hemangiomas. Those are actually quite frequent, often found incidentally in a vertebral body. Also bone cysts, osteochondromas, usually slow-growing.
And how do doctors classify how these primary tumors behave? Is there a system?
Yes, for primary bone tumors, surgeons often use the Enneking oncological staging system. It's not something we need to detail fully, but basically it classifies them based on their aggressiveness. Stage 1 is latent or inactive. Stage 2 is active but contained within the bone. And Stage 3 is aggressive, breaking out of the bone. It helps predict behavior and plan treatment.
So even benign tumors have different activity levels. What about malignant primary extradural tumors?
Malignant primary bone tumors are rarer, but include serious cancers like osteosarcoma, chondrosarcoma, Ewing sarcoma, or even lymphoma or leukemia involving the bone. These are aggressive and require specific cancer treatments.
Okay, now on to the secondary extradural tumors, the metastases. You said these are more common?
Much more common, especially in adults presenting with spinal tumors. The spine is a frequent site for cancer to spread.
Where does it usually spread from?
Common primary sources are cancers like myeloma, that's a bone marrow cancer that often affects multiple vertebrae. Also breast, prostate, lung cancer are very common culprits. Then lymphoma, melanoma, kidney, thyroid. The list is quite long, actually. Stomach, uterus, cervix, bladder, pancreas, even head and neck cancers can metastasize to the spine.
So a wide range of possibilities. How do these look on an MRI? What are the giveaways?
MRI is really the key imaging modality. For metastases, we often look for things like destruction of the vertebral body, maybe vertebral collapse. The bone marrow signal changes, it looks abnormal, often darker on T1 weighted images and brighter on T2, showing infiltration by tumor cells.
Does it light up with contrast dye?
Yes, usually there's abnormal enhancement after giving contrast dye. Sometimes you see a diffuse infiltration pattern, especially in things like multiple myeloma or lymphoma, where the marrow in several bones looks abnormal. And importantly, we look for extension to the epidural space, potentially compressing the spinal cord or nerve roots.
Is there another classification system used specifically for these extradural spinal metastases, maybe for surgical planning?
Yes, the TUMITA classification is often used. It describes the extent of tumor involvement within and around the vertebra. It categorizes tumors from type 1 to 7 based on whether they are confined to the vertebral body, involve the pedicles, the bony bridges to the back of the vertebra, extend into the epidural space, or even spread to adjacent vertebrae or surrounding tissues.
Why is that level of detail important?
It's crucial for surgical planning. It helps the surgeon decide on the approach, how radical the resection needs to be, and whether spinal stabilization, like putting in screws and rods, will be necessary after removing the tumor-involved bone.
That makes sense. It guides the whole operation. Now, you mentioned vertebral collapse. Pathological fractures are a big issue here, right? Fractures caused by the tumor weakening the bone. How do you tell a malignant fracture from, say, an osteoporotic one in an older person?
That's a really critical distinction radiologists and surgeons have to make, often based on MRI. A benign compression fracture, like from osteoporosis or trauma, typically shows some preservation of the normal fatty bone marrow signal, at least partially. The posterior elements, the back part of the vertebra, are usually intact. And importantly, the adjacent intervertebral discs usually look okay. Maybe some fluid signal, edema, but not typically destruction.
Okay, so some structure remains. How does a malignant fracture look different?
Malignant fractures often show complete replacement of the normal fatty marrow signal with tumor tissue. You might see destruction extending into the pedicles or the posterior elements. Convex bulging of the back wall of the vertebral body is a worrisome sign. Crucially, you often see associated epidural or paravertebral soft tissue masses of the tumor growing out of the bone. And the adjacent discs might be involved or destroyed too. Diffuse edema is also common.
So, much more destructive, invasive signs. That's a vital difference. Let's move deeper now, inside the dura but outside the cord. Intradural extramedullary tumors. You said about 15% of CNS tumors.
Roughly, yes. About 15% of all primary central nervous system tumors fall into this category. Their hallmark is being well demarcated. They arise from structures within the dural sac, but not the cord itself.
So they displace the cord rather than invading it.
Exactly. They cause a mass effect, pushing the spinal cord aside. On imaging, like an MRI or an older technique called myelography, you'd see the dye or the fluid-filled space being compressed and the spinal cord potentially flattened or moved over. You often see a widening of the subarachnoid space around the tumor mass.
What are the main types here? Primary ones first.
The two most common primary types are nerve sheath tumors, specifically schwannomas and neurofibromas and meningiomas.
Tell me about those, schwannomas and neurofibromas.
They arise from the Schwann cells, or other cells that form the protective sheath around nerve roots as they exit the spinal cord. Schwannomas are typically solitary, well encapsulated, and often enhanced brightly with contrast, sometimes with cystic areas. Neurofibromas can be similar, but are often associated with a genetic condition called neurofibromatosis type 1, NF1. They can sometimes be more elongated or plexiform.
And meningiomas.
Meningiomas arise from the meninges, the coverings of the spinal cord, specifically the arachnoid cap cells. They're also typically well encapsulated, often rounded or lobulated, and usually enhanced intensely and uniformly with contrast. They sometimes have a dural tail sign enhancement extending along the dura away from the main tumor mass. They're more common in women and often found in the thoracic spine.
Are there any primary malignant tumors in this space? like lymphoma.
Primary CNS lymphoma can occur intradurally, sometimes presenting as nodules or enhancing masses on nerve roots or the cord surface, but it's less common than schwannomas or meningiomas in this specific location.
Okay. What about secondary tumors spreading here?
The main concern for secondary spread in this space is leptomeningeal carcinomatosis, or leptomeningeal metastases. This isn't usually a single discrete mass like the primary tumors.
How does it present then?
It's more like a diffuse seeding or coating of the surfaces of the spinal cord and nerve roots by cancer cells that have spread through the cerebrospinal fluid, CSF. On MRI, you might see subtle or sometimes very striking linear or nodular enhancement along the surface of the cord, or coating the nerve roots of the cauda equina, making them look thickened and clumped together.
That sounds quite different from a schwannoma. What cancers typically cause this?
It can come from various primary cancers, often lung cancer, breast cancer, melanoma, or even leukemias and lymphomas, spreading into the CSF pathways. It indicates widespread disease within the central nervous system and generally has a poor prognosis.
Right, a much more diffuse, widespread process. Okay, let's go to the deepest level now, intramedullary tumors. Inside the spinal cord itself, you said these are less common.
Yes, definitely the least common location, making up maybe 5 to 10% of all spinal tumors and maybe 2% of all CNS tumors overall. But importantly, about 70% of these are a type called gliomas.
Gliomas, like in the brain.
Exactly, arising from the glial support cells within the spinal cord tissue. The main primary types we see here are ependymomas and astrocytomas. Another important one is hemangioblastoma.
Can metastases also occur right inside the cord?
They can, but intramedullary metastases are rare. When they do happen, they most often come from lung cancer, breast cancer, or melanoma. They usually appear as well-defined enhancing nodules within the cord, often with a lot of surrounding edema or swelling. But primary tumors are more common in this location.
Let's compare the two main primary ones, ependymoma versus astrocytoma. You mentioned this as a key distinction.
It absolutely is. They have different typical patient populations, locations, growth patterns, imaging features, and prognosis.
Okay, let's start with ependymomas. Who gets these? Where are they?
Ependymomas are the most common intramedullary tumor in adults. The average age of diagnosis is around 38, and they're slightly more frequent in males. They can occur anywhere along the cord, but are often found in the cervical spine, the neck, or the cumenus ocularis, the very bottom tip of the spinal cord.
And how do they grow? What do they look like?
They arise from the ependymal cells lining the central canal of the spinal cord. Crucially, they tend to grow centrally within the cord and expand outwards by displacing the surrounding cord tissue rather than infiltrating it deeply. This means they often have relatively well-defined borders or a clear cleavage plane between the tumor and the normal cord.
Does that make them easier to remove surgically?
Generally, yes. That clear plane makes complete surgical resection more feasible, leading to a better prognosis compared to more infiltrative tumors. On MRI, they often appear well circumscribed, they tend to enhance quite homogeneously with contrast, and they frequently have signs of associated hemorrhage bleeding, which can look like high signal on T1 images or low signal caps on T2 images due to hemosiderin. Cysts associated with the tumor are also common.
You mentioned the conus medullaris. Is there a specific type there?
Yes, there's a specific subtype called myxopapillary ependymoma. This type occurs almost exclusively in the region of the conus medullaris and the filum terminale, that thin strand extending down from the comoes. It tends to affect younger patients, often adolescents or young adults.
How does it look different?
It can sometimes be quite large, potentially causing bony erosion or scalloping of the vertebral bodies due to chronic pressure. Imaging can be more heterogeneous than typical ependymomas, sometimes with more prominent cystic components or signs of hemorrhage. Because it's near the end of the cord, it often presents with leg pain, weakness, or bowel bladder issues.
Is the conus ependymoma linked to any genetic conditions?
Ependymomas in general, particularly those in the spine, can be associated with neurofibromatosis type 2, NF2. So finding one might prompt testing for NF2, especially if there are other suggestive features.
Okay, so ependymomas, adults, central, well-defined, often resectable. Now, how do astrocytomas compare?
Astrocytomas are the flip side in many ways. They are more common in children than adults, with an average age of diagnosis around 29, also slightly more common in males.
Then location, growth pattern.
They occur more frequently in the thoracic, mid-back, and cervical regions. Unlike ependymomas, they tend to be eccentric within the cord off to one side, and critically, they're usually ill-defined and infiltrative. They grow by weaving into the normal spinal cord pathways, making it very difficult to find a clear plane for surgical removal.
That sounds much tougher for surgery.
It is. Complete resection is often impossible without causing significant neurological damage, which means recurrence rates are higher, and the overall prognosis tends to be worse than for ependymomas, especially for higher-grade astrocytomas.
How do they look on MRI?
They often appear as fusiform swelling of the cord, meaning it looks widened over several segments, sometimes spanning many vertebral bodies, maybe 7 on average, compared to maybe 4 for ependymomas. The enhancement with contrast is typically more irregular, patchy, or wispy, rather than solid and homogeneous. They are frequently associated with cysts, which can be either within the tumor, tumoral cysts, or reactive fluid collections above or below the tumor, reactive cysts or syrinx.
Any genetic links for astrocytomas?
Spinal cord astrocytomas can be associated with neurofibromatosis type 1, NF1. They're also often associated with scoliosis, or curvature of the spine, especially in children.
So, key differences to recap. Ependymoma adults, central, well-defined, better prognosis. Astrocytoma children, eccentric, infiltrative, trickier prognosis.
That's the core distinction, yes. It guides everything from surgical planning to expected outcomes.
You also mentioned hemangioblastomas as an intramedullary type. What's characteristic about them?
Hemangioblastomas are vascular tumors, meaning they're made up of blood vessels. They're strongly associated with von Hippel-Lindau, VHL disease, a genetic disorder, although they can occur sporadically too.
What do they look like?
They often present as a small, brightly enhancing nodule located on the surface or within the cord, frequently associated with a large cyst or significant surrounding edema, swelling, called vasogenic edema. Sometimes you can even see prominent feeding or draining blood vessels on imaging. Treatment is usually surgical removal of the nodule.
Are there other rarer intramedullary tumors we should briefly mention?
Yes, there are a few others. Gangliogliomas are rare, low-grade tumors containing both neuronal and glial cells, often seen in children and young adults. They can be large, sometimes associated with scoliosis and vertebral scalloping. Gangliomas are very rare neuroendocrine tumors, typically found in the filum terminale or cauda equina region, often very vascular and sometimes hemorrhagic. And then there are extremely rare things like primitive neuroectodermal tumors, PNETs, usually in the cauda equina region in children.
Okay, quite a spectrum even within the cord. Let's shift back slightly. You mentioned hemangiomas earlier as benign extradural tumors. How do they differ from the intramedullary hemangioblastomas?
Good distinction. Vertebral hemangiomas are very common benign tumors of the bone itself, the vertebra. They're often found incidentally on imaging for unrelated reasons. They have a characteristic appearance on MRI, often bright on both T1 and T2 images due to fat content, sometimes with a corduroy or polka dot pattern on axial views due to thickened bony trabeculae.
Right.
They rarely cause symptoms unless they expand significantly or fracture.
So totally different from the intramedullary hemangioblastoma.
Completely different entity, different location, bone versus cord, different cell type, different associations. Hemangioblastoma with VHL. Hemangiomas are generally harmless vascular malformations in the bone. Hemangioblastomas are true vascular neoplasms within the nervous system.
Got it. Thanks for clarifying. Now, pulling back to the bigger picture, how do doctors synthesize all this information? We've talked anatomy, types, imaging, but what about the patient's story? The clinical diagnostic criteria based on symptoms?
The patient's history and the pattern of their symptoms are absolutely crucial. Pain is often the first symptom, but how it presents tells us a lot. We mentioned 2 main patterns earlier.
Right, the dermatomal and sclerotomal types. Can you elaborate?
Yes. The dermatomal type often suggests irritation or compression of a specific nerve root. It's typically sharp, lancinating pain that radiates along the distribution of that nerve down an arm or leg in a specific pattern. It might be associated with numbness, tingling, or weakness in that same distribution. The onset can be relatively rapid.
And the sclerotomal type?
This is often described as a deeper, duller, aching pain that's harder to pinpoint precisely. It relates more to irritation of deeper structures like ligaments, joints, or bone that share innervation patterns. It might be associated with more diffuse neurological signs like muscle hypotonia, reduced tone, hypertrophy, muscle wasting, or hyperreflexia, reduced reflexes that don't perfectly fit a single nerve root. The onset is often slower, more insidious.
Beyond pain patterns, what else is key clinically?
Progressive neurological deficits are a major warning sign. Weakness that gets worse over time, sensory changes that spread or intensify, and as we mentioned, any signs of sphincter dysfunction, difficulty with bladder or bowel control, urinary retention, incontinence. These are critical red flags indicating significant spinal cord compression, potentially cauda equina syndrome, which is a surgical emergency. Signs of autonomic dysfunction, like changes in sweating or temperature regulation, can also occur.
So careful history taking and neurological exam are paramount. Once a tumor is diagnosed, what determines the path forward for treatment and prognosis?
It's a complex decision-making process, highly tailored to the individual. Key factors include the tumor's biology. Is it benign or malignant? What specific type is it? How fast is it growing? Is it invasive? Has it metastasized? And critically, what is the patient's neurological condition before treatment?
Does the pre-treatment neurological status really impact recovery?
Dramatically. For instance, as mentioned, patients who are already paraplegic, unable to walk due to cord compression before surgery, have a much lower chance of regaining ambulation, less than 30% typically. Early intervention before severe deficits develop offers the best chance for recovery.
What's the main treatment strategy?
For most symptomatic spinal tumors, the primary treatment is surgical intervention. The main goals are usually decompression of the neural elements, the spinal cord and nerve roots, and, if possible, exoresis, which means removal or resection of the tumor.
How is the surgery typically done?
Often via a laminectomy, where the surgeon removes the lamina, the bony roof covering the spinal canal at the affected level, to gain access to the tumor and relieve pressure. Then, depending on the tumor type and location, they proceed with resection.
When is surgery definitely the way to go?
Clear indications include a solitary primary tumor or a single metastatic lesion causing neurological compression, pathological fractures causing significant pain or neurological symptoms, tumors that are known to be resistant to radiation therapy, or spinal instability that develops either from the tumor itself or sometimes after radiation treatment.
What are the key things surgeons think about when planning these operations?
There are three main considerations. Access, choosing the best surgical approach to reach the tumor safely, with minimal disruption to normal structures. Exoresis, determining the goal of resection. Is complete removal possible and safe, or is debulking the goal? Based on the tumor type, for example, trying for complete removal of an ependymoma versus debulking an infiltrative astrocytoma. And stabilization, deciding if removing the tumor or involved bone will destabilize the spine, requiring instrumentation like screws and rods to maintain strength and alignment.
Wow, quite a journey from a simple backache to complex neurosurgery. We've really unpacked a lot today about spinal cord tumors, starting with that common back pain, but highlighting the rare possibility of a tumor.
We trace the path through the different locations, extradural, intradural, extramedullary, and right inside the cord, intramedullary, and saw how that location dictates everything.
We compared key types, like the often well-defined ependymomas versus the infiltrative astrocytomas, looked at metastases, and touched on rarer types, too.
And emphasized those clinical red flags, the specific pain patterns, the progressive neurological decline, and especially sphincter changes that signal something serious might be going on, leading into how treatment, primarily surgery, is tailored based on tumor type, location, and the patient's condition.
It really underscores that while these are uncommon, understanding the nuances is vital. The difference between benign and malignant, between displacing and infiltrating, between different imaging signs, it all matters immensely.
Absolutely. And the precision required, both in diagnosis and treatment, within such a delicate area as the spinal cord, is truly remarkable. It highlights the continuous advancements offering hope.
It leaves you thinking, doesn't it, about the complexity packed into our spines and the skill involved in navigating problems within it. What other subtle clues about our health might we be missing if we don't look closely?
That's a great point. Continuous curiosity and deeper understanding are always valuable.
Indeed. So keep asking questions, keep exploring. Knowledge really is power when it comes to understanding our health and the world around us. Thanks for joining us on the deep dive.